Indications. Cabometyx, cabozantinib, is indicated for the treatment of adult and pediatric patients 12 years of age and older with previously treated unresectable, locally advanced or metastatic well-differentiated pancreatic neuroendocrine tumors, PNET. Cabometyx is indicated for the treatment of adult and pediatric patients 12 years of age and older with previously treated unresectable, locally advanced or metastatic, well-differentiated extrapancreatic neuroendocrine tumors, EPNET. Select important safety information. The full prescribing information for Cabometyx includes warnings and precautions for hemorrhage, perforations and fistulas, thromboembolic events, hypertension and hypertensive crisis, cardiac failure, diarrhea, palmar plantar erythrodysesthesia, proteinuria, osteonecrosis of the jaw, impaired wound healing, reversible posterior leukoencephalopathy syndrome, thyroid dysfunction, hypocalcemia, and embryo-fetal toxicity. Please see important safety information at the end of this video.
Hi, I'm Dr. Katharine Thomas. I'm a medical oncologist at the Pennington Cancer Institute in Reno, Nevada, and an assistant professor of medicine at the University of Nevada, Reno.
Hi, I'm Dr. Andy Liao. I'm a medical oncologist, associate professor of medicine, and co-director of the neuroendocrine tumor program at the University of Chicago.
Today on Cabometyx in Conversation, we're going to discuss Scott, a hypothetical patient with a pancreatic neuroendocrine tumor, or PNET. In this conversation, we'll discuss his background, his disease, and examine how we would approach treatment for Scott in patients like him. Dr. Liao, let's look at Scott's case. He is a 60-year-old man with a medical history that's typical for someone his age. He has hypertension that is controlled with valsartan. He consumes alcohol occasionally and has no family history of malignancy. Scott presents to his physician with several symptoms. He began to experience weight loss, abdominal pain, and nausea. Following a CT scan of the abdomen, an enlarged left liver lobe and locally invasive pancreatic mass were identified. He underwent a biopsy of both the pancreas and liver. Based on the pathology results, Scott was diagnosed with a grade 2 somatostatin receptor positive, non-functional, well-differentiated pancreatic neuroendocrine tumor with liver metastases. He was deemed not a candidate for surgery and was ineligible for local regional therapies. With Scott's presentation of symptoms, he was started on PRRT with lutetium-177 dotatate in addition to octreotide and progressed 20 months after treatment. Before going deeper into our treatment approach for Scott, I want to ask you, Dr. Liao, what's top of mind for you when choosing next-line therapy, particularly in the context of intolerance to treatment or disease progression?
So top of mind, I know that neuroendocrine tumors, or NETs, are a heterogeneous group of malignancies with a range of biological behaviors. They can have a diverse presentation, which includes their histological features, their proliferation rate, hormonal production, molecular profile, and clinical aggressiveness. The pancreas is a location where neuroendocrine tumors can originate from and is generally more aggressive in biology compared to other sites of origin. Specific features of the disease may influence our treatment option. Some of these distinct features include sites of origin, somatostatin receptor status, functional status, tumor grade, disease pace, and/or tumor burden. So there are few treatment options for patients like Scott. Following octreotide and PRRT, I'm looking for a treatment option that has demonstrated efficacy in a robust study. I'll also consider the treatment safety and tolerability profile. For Scott and other patients like him, my preferred treatment of choice will be Cabometyx.
I see. Let's talk about what's driving that choice.
Of course. The evidence for Cabometyx comes from the CABINET study. CABINET is the first phase 3 study to evaluate such a wide range of both pancreatic and extrapancreatic neuroendocrine tumors. Patients were randomized 2-to-1 to receive either Cabometyx or placebo. Patients enrolled were required to have progression or intolerance following one or more FDA-approved systemic therapies, not including somatostatin analogs. Eligible patients in the placebo arm could cross over to Cabometyx after progression. I should also mention that due to the impressive efficacy results demonstrated at the interim analysis, the cabinet trial was unblinded before final pre-specified analysis, allowing the remaining placebo patients to cross over to Cabometyx. The trial's primary endpoint was progression-free survival, and the secondary endpoints included overall response rate, overall survival, safety, and tolerability.
That's a helpful background. Given that, how do you see Cabometyx as a potential option for your patients in clinic, considering the cabinet trial data?
I see Cabometyx as an excellent option for my previously treated patients with neuroendocrine tumors. One of the key strengths of the cabinet trial was that the patient population reflected individuals that I see in real life. To start, the trial included patients with a range of tumor grades, with most enrolled having grades 1 and 2, and some having grade 3 tumors. This gives me confidence in using Cabometyx for tumors of any grade. In addition, 64% of patients in the PNET cohort had received prior treatment with PRRT. Not everyone has access to or is a candidate for PRRT, so I feel confident selecting Cabometyx, knowing that it has been tested in both scenarios. Finally, the trial also included patients with various metastatic sites, including liver, lymph nodes, bone, lung, and the abdominal wall. It's also reassuring that patients were allowed to continue SSAs while taking Cabometyx. In my practice, I generally continue SSAs for patients with functional disease.
Those are great points, Dr. Liao. Treatment efficacy is an important consideration for patients with neuroendocrine tumors. With that in mind, when deciding on treatment for a patient like Scott, who is somatostatin receptor positive, non-functional, and progressed on PRRT, which cabinet efficacy endpoints do you prioritize?
I mainly look at progression-free survival, although I also consider overall response rate and overall survival.
That makes sense. How do Cabometyx perform with those endpoints in mind?
So let's start with the primary endpoint, progression-free survival, which performed well. Cabometyx quadrupled the PFS, 13.8 months versus 3.3 months, with a statistically significant 78% reduction in the risk of progression or death. Exciting to see data like this.
I agree that it's a significant improvement with Cabometyx versus placebo. What are your thoughts on the overall response rate?
Based on a descriptive analysis, patients receiving Cabometyx showed an 18% response rate compared to 0% in the placebo arm. This difference is meaningful, especially in previously treated patients with pancreatic neuroendocrine tumors.
I see. Building on that, what about the disease control rate?
I think it's helpful to look at these data together. 80% of patients experienced disease control with Cabometyx versus 55% in the placebo arm. This is a good proportion of patients with tumors that shrank or remained stable.
That said, you also mentioned overall survival data. What should we keep in mind about those outcomes?
Yes, earlier we discussed in the cabinet trial where eligible patients at progression and those unblinded early were allowed to cross over to open-label Cabometyx. Typically, this crossover may impact the overall survival results. In patients with neuroendocrine tumors who often have long life expectancy, overall survival can be influenced by factors such as the number of subsequent therapies, age, or unrelated causes of death. So it makes sense to me that the median overall survival in cabinet was not mature at the time of the updated analysis, especially with 52% of patients on placebo crossing over to Cabometyx. Obtaining mature overall survival data in clinical trials typically requires long follow-up periods, and meaningful overall survival data are not yet available for any of the existing neuroendocrine tumor systemic therapies. So I tend to look at progression-free survival as a reliable measure of efficacy in neuroendocrine tumors.
I agree. I would say maintaining stable, non-progressing disease is the goal for patients with neuroendocrine tumors in general.
Exactly. With the strength of these data, especially progression-free survival, I'd feel confident recommending Cabometyx to a patient like Scott.
Great. Now that we've explored efficacy, let's also look at the safety profile of Cabometyx.
Sure. The safety and tolerability of a treatment should be considered for each individual patient. In cabinet, the most common adverse reactions for Cabometyx were fatigue, hypertension, diarrhea, rash, and stomatitis. The majority of those adverse reactions were grade 1 and 2, But looking at those grade 3 or 4, the most common adverse reaction was hypertension, with an incidence of 25% in Cabometyx versus 16% in placebo. The three highest lab abnormalities occurring in the Cabometyx arm were increased ALT, increased AST, and hyperglycemia.
Thank you for sharing that. Given the safety profile, do you feel comfortable managing these adverse reactions in your practice?
Yes, safety is always a priority when considering treatment, and I have several strategies in mind to address these concerns and potentially improve tolerability. For instance, involving a nutritionist can be helpful for patients with pancreatic insufficiency, ensuring they get the necessary enzymes to properly digest food and absorb vitamins and minerals. Weight loss is also a common challenge in patients with pancreatic neuroendocrine tumors, so managing that is essential. Another thing to watch out for is PPE or hand-foot syndrome. In cabinet, rash, which includes PPE, occurred in 57% of Cabometyx patients versus 23% in placebo. It's a challenging adverse reaction that may lead to treatment interruptions, so it's important to manage it proactively. For example, moisturizing the skin regularly can help minimize its impact, and early detection followed by dose adjustments is the key in preventing more severe reactions. What are some of your strategies, Dr. Thomas?
When it comes to PPE, educating patients upfront is essential. This helps set realistic expectations, prevent surprises, and may help them feel more prepared for any situation. Fatigue is another prevalent issue, with 61% of placebo patients reporting it, compared to 79% in the Cabometyx group. This underscores the widespread nature of fatigue in pancreatic neuroendocrine tumors, and we have various tools to help manage energy levels and improve patient comfort. Nausea is something I also like to address aggressively, which can impact a patient's day-to-day life.
Yes, exactly. And since I've used Cabometyx in other approved indications, and cabinet trial showed no new safety signals, I feel confident talking with my patients about the potential adverse reactions and the management strategies that we have to help improve tolerability. And it's important to note that not all adverse reactions can be managed, and some may lead to permanent discontinuations.
Thank you, Dr. Liao. As we wrap up, can you summarize your thoughts on treating patients with pancreatic neuroendocrine tumors with Cabometyx?
Absolutely. Cabometyx was studied in a trial that included a broad range of previously treated patients, making it a potential option for many of the patients with pancreatic neuroendocrine tumors. Cabometyx demonstrated compelling efficacy results, particularly with progression-free survival that quadrupled compared to placebo in the PNET cohort. The safety data was consistent with the known Cabometyx profile, with adverse reactions that may be managed with a variety of strategies. For these reasons, I feel confident recommending Cabometyx to my previously treated patients with pancreatic neuroendocrine tumors.
Thank you so much for sharing your perspective, Dr. Liao.
My pleasure. I look forward to our next conversation.
And thank you all for watching. Be sure to join us for more expert discussions in our Cabometyx in Conversation Neuroendocrine Tumors series.
Important safety information, warnings and precautions. Hemorrhage. Cabometyx can cause severe and fatal hemorrhages. The incidence of grade 3 to 5 hemorrhagic events was 5% in Cabometyx patients in RCC, HCC, and DTC studies. Discontinue Cabometyx for grade 3 to 4 hemorrhage and before surgery. Do not administer to patients who have a recent history of hemorrhage, including hemoptysis, hematemesis, or melena. Perforations and fistulas. Fistulas, including fatal cases, and gastrointestinal GI perforations, including fatal cases, each occurred in 1% of Cabometyx patients. Monitor for signs and symptoms, and discontinue Cabometyx in patients with grade 4 fistulas or GI perforation. Thromboembolic events. Cabometyx can cause arterial or venous thromboembolic events. Venous thromboembolism occurred in 7%, including 4% pulmonary embolism, and arterial thromboembolism in 2% of Cabometyx patients. Fatal thrombotic events have occurred. Discontinue Cabometyx in patients who develop an acute myocardial infarction or serious arterial or venous thromboembolic events. Hypertension and hypertensive crisis. Cabometyx can cause hypertension, including hypertensive crisis. Hypertension was reported in 37%, 16% grade 3, and less than 1% grade 4 of Cabometyx patients. In cabinet, N equals 195, hypertension occurred in 65%, 26% grade 3 of Cabometyx patients. Do not initiate Cabometyx in patients with uncontrolled hypertension. Monitor blood pressure regularly during Cabometyx treatment. Withhold Cabometyx for hypertension that is not adequately controlled. When controlled, resume at a reduced dose. Permanently discontinue Cabometyx for severe hypertension that cannot be controlled with antihypertensive therapy or for hypertensive crisis. Cardiac failure. Cabometyx can cause severe and fatal cardiac failure. Cardiac failure occurred in 0.5% of patients treated with Cabometyx as a single agent, including fatal cardiac failure in 0.1% of patients. Consider baseline and periodic evaluations of left ventricular ejection fraction. Monitor for signs and symptoms of cardiovascular events. Withhold and resume at a reduced dose upon recovery, or permanently discontinue depending on the severity. Diarrhea. Cabometyx can cause diarrhea, and it occurred in 62%, 10% grade 3 of treated patients. Monitor and manage patients using antidiarrheals as indicated. Withhold Cabometyx until improvement to less than or equal to grade 1. Resume at a reduced dose. Palmar-plantar erythrodysesthesia, PPE. Cabometyx can cause PPE, and it occurred in 45% of treated patients, 13% grade 3. Withhold Cabometyx until PPE resolves or decreases to grade 1, and resume at a reduced dose for intolerable grade 2 PPE or grade 3 PPE. Proteinuria. Proteinuria was observed in 8% of Cabometyx patients. Monitor urine protein regularly during Cabometyx treatment. For grade 2 or 3 proteinuria, withhold Cabometyx until improvement to less than or equal to grade 1 proteinuria. Resume Cabometyx at a reduced dose. Discontinue Cabometyx in patients who develop nephrotic syndrome. Osteonecrosis of the jaw, ONJ. Cabometyx can cause ONJ, and it occurred in less than 1% of treated patients. Perform an oral examination prior to Cabometyx initiation and periodically during treatment. Advise patients regarding good oral hygiene practices. Withhold Cabometyx for at least 3 weeks prior to scheduled dental surgery or invasive dental procedures. Withhold Cabometyx for development of ONJ until complete resolution. Resume at a reduced dose. Impaired wound healing. Cabometyx can cause impaired wound healing. Withhold Cabometyx for at least 3 weeks prior to elective surgery. Do not administer for at least 2 weeks after major surgery and until adequate wound healing. The safety of resumption of Cabometyx after resolution of wound healing complications has not been established. Reversible posterior leukoencephalopathy syndrome, RPLS. Cabometyx can cause RPLS. Perform evaluation for RPLS and diagnose by characteristic finding on MRI any patient presenting with seizures, headache, visual disturbances, confusion, or altered mental function. Discontinue Cabometyx in patients who develop RPLS. Thyroid dysfunction. Cabometyx can cause thyroid dysfunction, primarily hypothyroidism, and it occurred in 19% of treated patients, 0.4% grade 3. Assess for signs of thyroid dysfunction prior to the initiation of Cabometyx and monitor for signs and symptoms during treatment. Hypocalcemia. Cabometyx can cause hypocalcemia, with the highest incidence in DTC patients. Based on the safety population, hypocalcemia occurred in 13% of Cabometyx patients, 2% grade 3 and 1% grade 4. Monitor blood calcium levels and replace calcium as necessary during treatment. Withhold and resume Cabometyx at a reduced dose upon recovery, or permanently discontinue Cabometyx depending on severity. Embryo-fetal toxicity. Cabometyx can cause fetal harm. Advise pregnant women of the potential risk to a fetus, and advise females of reproductive potential to use effective contraception during treatment with Cabometyx and for 4 months after the last dose. Adverse reactions. The most common, greater than or equal to 20% adverse reactions are Cabometyx as a single agent, diarrhea, fatigue, PPE, decreased appetite, hypertension, nausea, vomiting, weight decreased, and constipation. Drug interactions. Strong CYP3A4 inhibitors. If co-administration with strong CYP3A4 inhibitors cannot be avoided, reduce the Cabometyx dosage. Avoid grapefruit or grapefruit juice. Strong or moderate CYP3A4 inducers. If co-administration with strong or moderate CYP3A4 inducers cannot be avoided, increase the Cabometyx dosage. Avoid St. John's wort. Use in specific populations. Lactation. Advise women not to breastfeed during Cabometyx treatment and for 4 months after the final dose. Hepatic impairment. In patients with moderate hepatic impairment, reduce the Cabometyx dosage. Avoid Cabometyx in patients with severe hepatic impairment. Pediatric use. Physial widening has been observed in children with open growth plates when treated with Cabometyx. Physial and longitudinal growth monitoring is recommended in children 12 years and older with open growth plates. Consider interrupting or discontinuing Cabometyx if abnormalities occur. The safety and effectiveness of Cabometyx in pediatric patients less than 12 years of age have not been established. Please see accompanying full prescribing information. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088.